Okay, so that for the sake of time, we have to move on to the next session, which will have another interesting live demonstration cases from Asan Medical Center in China, and we also have two feature lectures. And I would like to invite the panels to the podium: Dr. Alkatiri, Dr. Chui, Professor Hong, Professor Seung-Jung, and Professor Nam, and Professor Suesat, and Professor Sugaya. I'm Dr. Gu from Seoul National University Hospital, and it's my great honor to co-moderate this session with Professor S.J. Park from Asan Medical Center.
Thank you. Dr. An, can you hear me? All right.
Yes, I can hear you. Before starting the second case, second live demonstration session, I'd like to show our final, the minimum stand area after the crush technique,
Obviously, right.
crush procedure.
Great.
Could you show us the, okay, this is, which one? Could you show us the final minimum stand area of circle ostium? Okay, this is the circle ostium. 6.71.
Big enough.
So, yeah, I think it's big enough.
All right.
So among the all components of left main bifurcation, I strongly believe that the circle ostium minimum stand area is the most important predictor for the future event. So 6.71 is quite a big circumflex ostial stand area. So I definitely believe that this patient long-term prognosis is during the 3-year follow-up, definitely event rate is less than 5%.
What of the LAD?
So could you show us LAD?
Very nice. Wow.
LAD is 12.
Big.
So big enough.
Yeah, really big enough.
No stenosis error, right? No restenosis error, right? We're going to expect that, right? Okay, good. Nice result. And so you want to do second cases?
Yes, second case is, I think this is a very interesting case.
All right.
So I'd like to introduce our team. So Junghoon Lee from St. Mary Hospital in Pyeong. So my senior, the fellow Han-Soo Park. So Han-Soo Park will introduce our case.
Okay, thank you. Let me introduce this case. This case is a 61-year-old male, and he underwent PCI for non-STEMI about 1 month ago at the proximal medial RCA. However, after the PCI, he persistently chest pain was occurred. Previous stent was giant sky point 4.0, 23 millimeter, and 38 millimeter. Next. He had hypertension, and his clinical presentation was stable angina. Next. ECG showed sinus bleeding with T-wave inversion at 2-3 ABF beat, and rare PVC was observed. Next. Chest X-ray showed no significant finding. Next. Echocardiography showed mildly reduced LV dysfunction and a kinase of inferior basal wall motion. Next. In coronary angiography, previous stent was patent in RCA, and in caudal view, we can see the mild stenotic lesion at the ostium of LAD and distal circumflex artery. Next. In cranial view, we can see the diffuse stenotic lesion at the mid-LAD and diagonal branch. Next. The target lesion is LAD and diagonal bifurcation, and we plan the IBUS guidance PCI.
Okay, thank you, Dr. Park. So could you show us the coronary angiogram?
All right. Mainly, this is mid-LAD and diagonal branches, mid-LAD.
Yes,
And
you can see there's some very, we don't know this left main or LAD ostium. There is overlapped area, there is some tight stenosis, and diffuse calcify from the whole LAD to the mid-LAD portion, and some relatively good size diagonal branch coming from in the middle of disease.
So
Next, please.
would you include this patient with Fei Ye main trials? Or not?
Actually, not. Could you show?
All right.
Could you show later? So explain the why.
All right.
So next, please.
Focus on the LAD and diagonal
Next,
branch,
please.
right?
Yeah. So very calcified LAD. So the deep array cranial view. The distal lab main looks fine, but the LAD ostium, very eccentric
Right.
stenosis.
Some disease over there, right?
Yeah, so mid proximal LAD, diffuse calcified lesion, and to the mid LAD. So from the beginning, I thought that this is a very diffuse disease. We need a very long stent. Even though for the calcified lesion treatment, intravascular imaging is very important. So we evaluated IVUS first. So could you show us that IVUS? IVUS start from the mid LAD.
Looks normal. 3O.
Yeah, 3O. So this is the distal tight stenosis portion. At
very
the site
tight
of
stenosis.
yeah. And here is the below the diagonal branch.
Relatively soft plaque, right?
Yeah.
However,
So diagonal branch coming from the 11 o'clock, very tight calcified stenosis. And this is above the diagonal branch. And some aneurysmal change. Here is another stenosis, just below the septal branch. Big LAD proximal, huge positive remodeling. But lumen looks good. Here is some plaque rupture, but lumen looks good. Here is a very proximal LAD ostium. And then here is a very ostium. And this is the lab main. Lab main is some plaque, but the lumen is very large.
proximal LAD disease is not so severe, right? Rather than
Yeah, right. Could you
angiography
show us the
findings, right?
proximal osteal disease?
There on?
Here is the proximal LAD. Some rupture, but the lumen looks good.
Rupture from the 4 o'clock, 6 o'clock. Encircling.
Stop, please. Stop. Here is the eccentric plaque based on the angiogram. This is IVUS finding.
Minimal,
Vessel is big.
minimal
Could you measure
lumen,
the minimal lumen?
lumen area is good, right? Would you
Yeah.
measure that one?
Roughly 7,
Whoa,
almost 8.
you know.
So it's I think quite enough for functional concept.
Yeah, I think this case illustrates how nice to use the intravascular imaging in this kind of hazy-looking, unstable coronary syndrome patients, even if this is a state procedure. So to me, to my eye, it looks like LAD ostium has some haziness there. Some may consider this is a kind of a rupture or the thrombus or the calcification, and now we can get to know that there's a kind of nodular calcification there. There shouldn't be functional significance, so that it can clearly define the treatment strategy for this patient.
Totally
So
totally different concept, you know, reality in biopsy compared with the coronary angiography finding. And so, Dr. An, what would you do there?
yeah, I think that I want to make a simple procedure. So ready? Another concern is the diagonal branch. Ready? Ready? So diagonal branch is not so small, but diagonal branch is a diagonal branch. So after high pressure balloon tube calcified plaque modification, diagonal branch flow is good. I want to just a simple crossover.
Sure.
Actually, we don't like to touch the proximal LAD. So angiographically looks like a very diffuse disease, but based on the IVUS finding, we can cover the whole region only one stent.
All right.
So 3O high pressure balloon, please.
For the LAD.
Yeah.
What size? What size?
So my target distal landing zone is just below the distal lesion.
Right, septal, next to
Yeah.
septal, right.
Yeah, right. And then
Just
the first septal branch.
all right.
This is 3O high pressure balloon. we know the LED, mid LED is more than 3, vessel size is more than 3O. So test please. Okay.
Okay.
10,
10, 10,
12.
12.
So balloon is well expanded. Deflation. 10,
10, 10,
deflation.
So in previous lecture
10,
by Professor
10.
Bach, we learned that the
12,
simple
13,
ischemia
14,
does not mean everything, so
16,
that the relevance of that branch is important. So in this bifurcation case, having that, applying that concept is very important, because if this is a true bifurcation lesion, if you simply think about anatomically, you may consider a kind of two-stent strategy for this patient, but the applying that concept, it's become very simple. So that which means that how that kind of concept implied in this procedure makes our procedure complex lesion into really a kind of simpler procedure. So that's a kind of a progression of the concept.
So
great.
sometimes when we treated the diffuse calcified lesion, after the high pressure balloon, the balloon dissection occluded the side branch flow. But fortunately, in this case, the side branch flow looks fine. So I selected 3O. The lesion length is based on the IVUS is 48. So I'd like to implant the 3O 48 stent.
Just a diagonal branch crossover, right?
Yeah, right.
All right, great. It's distally size-wise, a relatively big one, however, it's not too much compromise. Team is 3 floor, maintain. I think it's quite good.
So in this case, I'm using the XB guiding catheter. So I think we need a strong backup because of calcified lesion. But the stent delivery looks fine. Test please. Test. Test.
Perfect.
One more test.
Yeah.
Okay,
Perfect.
good. 10,
10, 10,
12,
12.
deflation.
It's very reassuring to see the contrast injection, considering the previous zero contrast angioplasty. I'm very happy to see the contrast injection.
16,
16,
18,
18,
deflation.
Perfect.
AKG.
Even in the calcific lesion, balloon expansion is perfect. It's quite good.
Let's just see the diagonal branch.
I think
Ready?
it's good. Perfect.
So I think the wire, please. Shion wire, please. Because Oliver ST elevation in the lead 1, so I think I need the zoom out and then ready.
ready.
Oh, some slow flow.
61. All right.
Yeah.
Patient had any chest pain?
No chest pain, but the ST elevation in the lead 1.
Really?
Yeah.
All right, great.
네.
So this illustrates why we need a kind of a wire position at the diagonal branch, even if it's small, because something happened. It's a kind of guide to the further procedural
주세요.
wiring.
Antonio Colombo always told us that nobody blame when you insert wire to the diagonal side branch. So in this case, I'd like to apply the small balloon to all.
2,
Yeah,
compliant.
yeah, complying.
Just
Then-
be careful of wire.
So Dr. An, what's the name of the guide wire at the diagonal branch?
Shion wire.
I think it's okay, right? High pressure. Great.
4, 5, 6. Take a time. My purpose is just to keep it open. Don't make a big dissection. And
Don't make a dissection, but
Deflation.
just low pressure inflation,
Okay.
chemistry fluid,
Ready? Okay.
perfect.
Yeah. So after I was evaluation, I want to do the LAD optimization, and then after LAD optimization, I'd like to do the final kitchen balloon to the diagonal branch and LAD. I'm not sure the DB would be effective for this situation, but anyway, based on the recent data, I'd like to do DCB for diagonal branch and the final kissing balloon using the DCB for diagonal branch. The ST elevation is disappear.
All right. Anyway, side branch wise, high pressure. Oh, well.
Okay, run please. So, as already the state box are saying that the
Sure.
main branch is more important. So even though jailed side branch, we have to optimize the LAD stand because patient long-term outcome should be determined by LAD stand. Definitely we need the 35.
All right.
Diagonal branch wire is coming from the 9 o'clock.
Stand opposition is good.
Yeah.
All right. So it's a 3-0 stand. No modification.
So proximal, we need actually 4-0.
Yeah, some malposition is there due to the kind of ectatic changes of the
Yeah,
coronary circulation.
right. Oh, proximal is very nice.
This is good. Right.
So some dissection, but I don't like to cover it. So please give me the short balloon of 4-0. 4-0, 8 or 10.
You want to do high pressures?
Yeah.
All right. And the diagonal branch concern, there are many options. However, you do 2-0 balloon, achieve the chemistry floor.
Yeah,
I
right.
think it's just leave it alone is another, another
Okay,
option
I-
for that, right?
Yeah, I agree
No
with your
dissection.
Yeah.
So in that perspective, I think selection of the arrow kit balloon. So if you want to fully open it, you have to use a 2.5 high pressure, then the large dissection maybe ended up with the additional stand. But the reasonable 2.0 nominal pressure, just open to maintain
14.
symmetry. So that's another important point we should discuss.
Deflation.
You know that, Dr. Koo, you know that the ostial part of a diagonal branch is relatively more than 90% had a slight negative remodeling there, right? So you compare with the distal part of diagonal, size-wise, a relatively small balloon, we have to choose that one, right?
6,
Great.
8, 10. Deflation. 3-0, use the one high pressure balloon, please. This is a 4O high pressure balloon.
So Professor Park, now Jung-Min just mentioned about applying DCB at the side branch. So you've been experienced the kind of balloon angioplasty, bare metal stent, drug-eluting stent. Then some are moving back to the balloon angioplasty for this small branch. How do you feel about the applying DCB in this side branch?
Side branch, actually, we need more data. I think so, right? However, relatively small vessels, so maintaining, in terms of lease and also something like that, maybe we can imagine is a little bit beneficial. So, however, we need the data, and then big vessel concern more than 2.5. Stent would be definitely better than that. The balloon.
This
right?
is a 3O high pressure balloon, 16. 18. Deflation. 20. 24. Deflation. Okay, this is a high pressure balloon.
Perfect.
So angiographically very diffuse calcified lesion, but after IBUS evaluation, we selected a relatively simple procedure, just one stent crossover, and I'd like to show you that the final angiogram. Ready? Nitro, please. Okay. Ready?
All right, still.
Okay.
So the question is still that there seems to be some dissection in the diagonal branch, but I guess that the patient no symptom ST elevation resolved.
All right.
So,
Resolved, yeah.
Yeah, so the question is
Alright.
whether you need to do something for that branch or just leave it alone.
Perfect.
Yeah.
All right.
There was
So the
final result is
yeah,
really good result. Right now,
we meet. Yeah.
So yeah, please go ahead.
You cannot touch that.
Okay, he already announced that you cannot touch, but if you want, so after camera off, you can do that. Okay.
Ready?
Okay, so
I
it
think
looks
it's
much
perfect.
better after removing the wire. It looks much better.
Ooh, great. Let's comment on that one. Good result. Any discussion point? Actually, by our examination, we're gonna save unnecessary procedures for the at least osteal prox LAD concern, and functionally, so we got a lots of ideas. He's a physiologist, Dr. Gu. He's just leave it alone. It may be better. It's a totally, good result. Dr. An, would you?
Yeah.
All right.
So usually when we evaluated IBUS, we need more stent and longer stent. But this is a very unusually different scenario. Based on the IBUS findings, we can change our strategy from the more complex procedure to the simple procedure. Yes. So everything is fine. Many side branch flow will get better.
Getting better.
The time goes by. Yeah. So I'd like to finish my procedure. I think the LAD stent is more important than other the diagonal branch fate. So we optimize the LAD stent using high pressure balloon. Definitely he will get better, and the long-term outcome should be good.
Really great cases, Dr. An. Thank you for that. All right. We're gonna move second one, Dr. Park, Duk-Woo Park. Can you hear me?
Okay.
Can you hear
Okay.
me? Right.
I can hear you well. Okay. Can you hear me well?
Right.
Yeah, we can hear you
Okay.
clearly.
So we also prepared that this session is a bifurcation session. We also the same and same topic is a non-left main LAD bifurcation region. I'm D.W. Park from Asan Medical Center, and the first assistant in the Professor Hanbit Park and the Gangneung Asan Medical Center, and he's chief in over there, and our senior the fellow and the Soo-yeon An in the standby, and we start the patient presentation. Okay.
Thank you. We have a 55-year-old gentleman referred for exertional chest pain. The initial coronary angiogram showed a focal severe stenosis at the posterior lateral branch of RCA and diffuse severe stenosis at the mid-LAD bifurcation. PCI at RCA was performed 3 weeks ago, and revascularization of left coronary artery was planned. Next. The patient has hyperlipidemia and mild carotid stenosis bilaterally. Next. Electrocardiogram showed normal sinus rhythm with heart rate of 66 beats per minute. Next. And chest x-ray showed no signs of congestion. Next. The patient has normal LV systolic function and the treadmill test was negative. The CT scan shows severe stenosis in distal RCA, PDA, and 2 diagonal branches. Next. The initial angiography showed the posterior lateral lesion, and we successfully treated the lesion with inserting drug-eluting stent. Next. And the left coronary angiogram showed diffuse severe stenosis and mid-LAD. Next. And the cranial view shows there's disease involvement in both diagonal branch. Next. And this is the plan for today's procedure.
Yes, and I'm going to show the first angiography, and this patient, the relatively young, and the first coronary angio, and 54-year-old, and presented upper chest pain and the stable angina. Could you show us the first view? So, and this is the right distal RCA is very tight. We already treated well a couple of weeks ago. And the suck is a big size, but mild disease. And next one. So, and this is the epicranial view. You can see there is absolutely a true bifurcation region, the involving the proximate LAD and the diagonal branch, not so small. There is also a very tight diagonal ostium stenosis. And next one. Next one. Okay, the previous one. So previous. So, and at this moment, I would like to propose the panel and how you treat this patient. This is a non-left main true bifurcation region. Diagonal branch is not so small.
2 big diagonal branches and diffuse LAD region. So, any
Okay. Yeah, it's definitely true bifurcation region, and then angiographically diagonal branches looks big, more than 2.5. But the issue is how much myocardial territory is involved with this diagonal branch. So the diagonal looks, it's third diagonal, right? It looks
Yes.
like. So it is a rare chance to more than 10% of myocardium. So I'd like to start with the provisional approach.
Cool.
Yeah, I also agree that it seems to be a big branch, so that you start with the provisional strategy and considering the side branch DCB in this case because the branch is big.
Okay. Dr. Hong, Seung-Jung, Bon-Kwon Koo.
Yeah, I would also proceed with the provisional strategy. So maybe look at the IVUS imaging at the LAD first, and then stent the LAD and see what happens to the diagonal branch.
Absolutely. Okay.
Any further ideas from the panels? Agree?
Yes. Thank you. So I think actually in this view we cannot really see the end of the diagonal. So it's quite long, meaning that I think we have data also concerning more than 73 mm of diagonal. And this is definitely more than 2.75 of diagonal. So we have to be really careful. Managing this diagonal. What I would do is probably do a very good lesion preparation, especially is the ostial of the diagonal. with NC, or probably it's a scoring balloon just to prepare. And what I usually do is doing a hybrid approach using a DCB for the side branch to make it more simple.
Yeah, this is a one zoom, and diagonal branch much looks like a bigger.
Yeah, it's quite long.
Bigger and longer.
Yeah, bigger and longer.
So, Dr. Bang, did you do?
Yes,
the
so,
obvious-
and you know, this is absolutely the true bifurcation region. We already checked the imaging, and the intracoronary imaging is so essential, this patient. So we prepared the different imaging modality. You know, you remember last year at the time of the ESC hotline session, and in our Octopus trial is the same big trial, is October trial, was presented in the ESC and published in New England Journal of Medicine. And so for this case, I would like to show how we do use the OCT guided PCI for treatment of true bifurcation lesion.
Great.
I think even in the same issue with Professor An, this is a non-left main bifurcation region, and I would like to propose some different taste. It's like some 흑백 요리사 Netflix series. So we already checked up the OCT. Can you show us the OCT?
Great.
Is it from the LAD? Okay.
Digital? All right.
Yes, this is you know, co-registration is so important, as you can see. And 뒤에서부터 다시 볼까?
Some
And
calcium
you
on
can,
there?
yeah, you can match the OCT tip position, and then where the position over there, and we can see evaluation from the distal LAD, and the coming out over here, and here is most tighted portion is quite narrow, and then we will pull back. This is a 7-branch XB without side or. We just use hand injection. Hand injection is okay. We can evaluate very clearly, even in bifurcation region. And the region is very long, and the diffusely extended in the proximal part. This is also very narrow, the part, lumen area less than 4. And on the basis of IBUS, and the region length is very long, 34. Also, if you decide the stent sizing, there was a recommendation in October trial, also the consensus in the European the EA-PCI registration. Some physician the proposed lumen-based the stent size. Some proportion in Illumin trial group proposed the EEM-based sizing. If you decide to the distal part, and you point out over here in the distal reference area, and there we will measure the EEM size. Can you show how can you measure the EEM size over there? Over here, this is the distal part. You measure the EEM, and this is EEM is 2.78. I think we usually select EEM-based lumen sizing. So I think this patient is considering the diffuse region in the proximity. We can select 3.0 long stent, and then the distal part is a small dilation, just a minimal dilation, and proximal part is a much higher dilation. Also, the next one, we also check the diagonal branch.
Great.
Yes, could you show second view? Yes. Okay, this is a diagonal branch without any pre-dilation. You can see have nothing. Not contrast injected well over here. And at this moment, we absolutely can consider pre-dilation. That is true in the Illumin 4 trial, in October trial. If not showing well in the OCT imaging, you do pre-dilation using 2.5 compliant balloon, and then recheck the diagonal branch. This is a recheck the post-diagonal branch. So, and you can see the distal part is not small, absolutely.
Big
here
vessel
is a very narrow part. Also, we do hand injection and dissection, and you can see the ostium of diagonal branch. Already dissection is shown over here, and then it's merged to the left main branch. So even using the OCT and the very clear image, we can easily achieve on the basis of the OCT, the imaging. We decide to EEM is the diagonal branch 2.75 is okay, and the regional length is 22. So, and on the basis of OCT guided imaging, we would like decide to upfront two-stand strategy, the diagonal branch. We're going to put the 2.75 and the LAD branch, and we're going to put the 3.048 drug-eluting stent. Okay, we showed everything in the OCT and introduced different tests. Any comment for imaging or?
Dr. Park, what was the reason for choosing OCT instead of IVUS for this patient? Do you have like certain criteria for choosing IVUS or OCT?
This is the live demo. So.
He's already mentioned that this is to show the different taste
Yeah.
of the live demonstration. But
So, and
actually,
yeah, okay, go ahead.
actually, he doesn't like OCT.
여기 스탠이야? 요거 먼저 자, LAD, the NC balloon.
But Asan Medical Center already elegantly demonstrated that it's just your choice. Octopus trial show that
Absolutely,
non-inferiority, so that you can either choose OCT, either choose IVUS. It's fine. And
Yeah.
the October trial,
Right.
that's the only bifurcation PCI trial. OCT showed
이게
the
지금 뭐지?
superiority.
LAD
So
지?
reasonable selection of the OCT for this case.
So you want to do the two-stand, right?
Yes, I'm going to do the
two-stand.
two-stand. And so, even after publication in October trial in the New England Journal of Medicine, I know in the many centers the still hesitation use of the OCT. Is many the interventional cardiologists still the OCT use is much burden rather than the IVUS. But if you have some experience, you can freely use the OCT guided PCI for the bifurcation region. Sometimes we can use in left main region, diffuse region, and calcify the region in afternoon live case. And I'm going to also introduce OCT guided PCI for the very severe calcified long region. So this is we're going to do the balloon crush. This is a 3.0 LAD, and then based on the OCT, we select 2.75 22, 23 giants. So, and in our cath lab, we usually use a hand injection. If you select guiding catheter without sidewall, you can achieve the very nice image. And as shown in the yesterday case, Dr. Wu, they used the 10% dextran. We don't have experience dextran. There is some safety concern. Is it like some anaphylaxis or some side effect? But we didn't have a concern. But yesterday, the dextran image is very nice. So we can consider in the CKD patient. This is 2.75. Okay, test. Okay, much pullback. Okay, test. Okay, I'm gonna move to another view. Okay. 한번 찍어보자. Angel. Good. And then inflate, sidewall. Just a nominal 8. 2.75. Okay. Deplete. And then slightly pull back the diagonal. Okay, go. 10, 12, 14. Okay, deplete.
Great.
And 275 NC balloon. And before crush, and as many years we already shown, we do much high pressure dilation. People remove the wire. There was a much easier to access the side branch wire, and then the side branch ostium configuration.
Sometimes, we miss that process to make the following process very complicated. So I think it's a good point that Dr. Bach, after stenting implantation and pulling back a little bit high pressure and then do additional high pressure non-compliant balloon, and that's a very important step to reduce the further procedure burden. And I think that with these procedures, we don't definitely need a kind of decay procedures for these complex lesions.
Okay, this is 275. Okay, go. 6, 8. Okay, deplete. This is 2.75 NC balloon.
NC balloon.
Go.
High pressure.
8, 10, 12. 14. Okay, deplete. Okay, go. 10, 12, 14, 16, 20. Okay, deplete.
A little bit bigger than.
And then they remove the wire. 어떤 이게 다인 거지? Okay.
Positioning of the proximal edge
Okay,
of the
여기
stent
잡고.
seems to be kind of perfect.
자, go. Inflate. This is 3.0. 12. Okay, deplete. 좀 빼서. 자, go. 12, 14. Okay, deplete. 그다음에 3.0, 48. The giants.
Balloon crush first.
Yes. And the Professor Hanbit Park, and he's our alumni, and this is a very, 4 and 5 years people live.
So I'm wondering who did the contrast injection for OCT?
Usually, and our technician or fellow, it doesn't matter.
Okay. Because
Yeah.
it's surprising that this is not RCA, but the LED with lots of branches. But it's surprising how you can make that nice OCT images only with
right.
contrast injection.
Absolutely. If you use the non-side hole guiding caster, and that is make sure it's much a very clear image. Okay, test. Okay, 여기서 앞에서
Further.
맞춰볼게.
All right.
자, 테스트. 여기는 됐고, 앞에도 한번 보자. 이 48. 자, 테스트 again. 오케이, 딱 맞아 보인다, 그지? 자, 여기서 한 번 더. 테스트. 오케이, 고.
Good.
12. This is 3.0. Okay. Deplete. Also, at this moment, we need a very aggressive high pressure balloon for the LED part. In the, the Niels and introduced in the October trial is very important sub-study. You don't do the high pressure balloon people entering the side branch. That cause some luminal wire insertion. That was caused very, mal crush the side of branch ostium part. And so if you use the OCD part, people entering the side branch wire, and you definitely certainly make sure the high pressure balloon was well done, and then the overall strut was well crushed, and you try to access the side branch, the high pressure through NC.
So that I also agree that that's a very important lesson we have to take in our mind. Even using OCT, there was a kind of mechanical complication happening more than 10% in October trial. And unless you fix it according to the OCT finding, even using OCT will not guarantee a good outcome of those patients. So that
Absolutely, yes.
Simply using OCT may not guarantee the good outcome, but how to use it and how to fix the problem, you find it through the OCT, and that's the key issue of successful OCT-guided bifurcation PCI.
자, go. Nominal.
What size? 3.0?
3.0.
All right.
Okay. Deplete.
High pressure.
자, 12, 14. 3.0. Okay. Deplete. 자, 16, 18. 20. Okay. Deplete. Okay. 20. Okay. Deplete and 3.5 NC balloon. So, and the last year I remember at the time of the ESC meeting, my session is an October trial, and at the press conference, and the Niels introduced October trial, as well as Gregstone introduced Illumine 4 trial. I'm very surprised initial hearing the October trial result, also Illumine 4 trial. Illumine 4 trial, absolutely negative trial. October trial, absolutely positive trial. I'm very surprised hearing the October trial. Wow, OCT guided bifurcation PCI achieved the primary result.
So when we
So
compare
even-
the Illumian in October, we understand that how enthusiastic the investigators for the
Absolutely.
training of the
Absolutely.
training of the
Yeah.
participants. So without that kind
Yeah.
of training and very complicated predefined protocol, we cannot achieve the clinical
Absolutely.
difference.
That is so important. And you know, in the October trial, and the PI center tried to educate all center, and hands-on and on virtual, and that is so important. Okay, go. Nominal. 12, 14, 16. Okay, deplete. Okay, go. 16. Okay, deplete. 위에는 컸어요, 그죠? 잠깐만요. Okay, 20.
So it's interesting that based on pre-OCT,
Okay,
Dr. Bach
deplete.
is practically doing the zero contrast angioplasty
go.
because he's already pre-planning everything, so he doesn't need
Yes,
any
yes.
contrast injection
Yes.
for that.
Okay, deplete. This patient, the young patient, his creatinine is absolutely normal. So, and I'm going to show a picture over here. And we have just one step and the final high pressure balloon, kissing balloon dilation. Okay, angio. Good.
Perfect.
나이트로 좀 주고. Yes.
Like it.
And then we're gonna recross the side branch. So, and like this, and even using the OCT, and you can freely use the bifurcation PCI. Is a, you know, timing of a procedure is much shorter using the OCT guided PCI. Just a one shot pre-procedure, and then final shot. That would be okay.
One very practical difference between current version of OCT and current version of IVUS to me is the co-registration. So especially for the beginners, when they do the IVUS, they don't know where is where. So it's very difficult to co-register by our brain power. But this new OCT system provides co-registration and
Yes,
easily
yes, yes.
makes us understand where is where and
Yes.
easy to plan the procedure.
So, and the current version, and you can check it up, the co-registration at which point, which OCT tip over there, and there is a very easy to make sure your position. Okay.
Dr. Koo, I would like to ask regarding the software that the OCT have, like the Ultron 2.0. How do you see this giving more advantage while doing the procedure?
Yes, with the advanced new software, AI-based technology, now that system can provide
Perfect,
even
perfect.
the vessel area. So I think that will definitely simplify our
볼륨을 좀 작은 거
procedures.
2.0. 여기를 바이퍼케이션은 3.0 NC 해도 되겠죠? 여기 안 들어갈 수 있으니까 3.0 NC를 일단 먼저 주고 앵커링 할 수도 있으니까. 오케이. This is used for.
You still have 7 minutes before we move to the Nanjing, so please take your time.
Okay, okay. Yeah, it's almost done.
Yeah, so please take your time.
Yeah. So. And in the country, and still the overall penetration of use of OCT and IVUS in the so different in many Japan center, and still think about OCT is some use for the investigational purpose and the routine use in the real world. 이게 어떤 거 사이버지? 이게 사이드 벤처. Routine use in real practice, and somewhat still hesitated. So I think absolutely, if you have some experience in the OCT guided PCI, and you can widely apply for in the very diverse region. Absolutely, I'm not representative of Abbott. Yes.
But even beside the Abbott now, many companies wants to have an OCT.
자, 여기서 요거 아니 이제 앵커링 한번 살짝 해봐. LED. 고 6, 8. Okay. Okay, go.
Okay,
That's deplete.
Anchoring
This is 2.0,
and LED
yes.
and push in.
자, go.
그러죠.
10,
For the
12, 14,
okay, what size of
16,
okay.
2.0.
2.0.
Okay, deplete. 자, one more time, 20. Okay,
Too small.
deplete. So we have just only one final step, final kissing. 2.75.
So as everything, all procedures were going so smooth, we didn't talk about how we crossed the side branch, because that you crossed the wire even before we begin to discuss that issue. So that it's very smooth and very nice.
Yeah. As shown yesterday in my lecture, our OCT guided PCI state of art review article was just published the October, a couple of weeks ago. You know, if you read that the review article is a brand new article, we introduced many diverse complex cases, left main and the bifurcation, calcified region, you know, the not open access. 오케이, 잠깐만. 여기 와이어 한번 썼던 거다, 그치? 앵커링 한번 해봐. 안 들어가면 U1 써야 될 수도 있어. 6A. Okay, good. Deplete. Everything is too much smooth.
Yeah, it's too good.
이게 LED지? 자, go. LED inflate. 10, 12, 14, 20. Okay, deplete. 이게 diagonal.
So Dr. Park is so smoothly
diagonal.
performed this complex procedure, so
12,
we don't concern
14,
about the rewiring
16,
location, but usually
Okay,
when you do the
deplete.
imaging guidance
한 번만
bifurcation
더 하자.
PCI, you
20.
usually recommend the imaging evaluation after rewiring of the side
좀
branch.
누르고 있어.
I think it's
wait.
quite enough.
Wait.
Quite enough, right?
Wait. Okay, deplete. So, 자, go. 6, 6.
Perfect.
I think this is a very good demonstration how Dr. Park really
seven.
do side bram optimization
Okay,
before
자,
doing kissing.
1, 2,
Because this
3.
is some stage that sometimes the operator forget. This is very important. Because when the first time Dr. Park dilate the ostial part, we can see the dog bone. But when he went up to 20 ATM, then it's becoming more beautiful.
Right. So using that angiographic view, we don't even need a kind of intravascular imaging is for that,
나이트로 좀 주고.
fixing that problem.
Okay, we will show the final, OCT and okay. 자, and you're ready? Good.
I think it's perfect. Would you show
LED가
us
이건가?
a little bit aerial view, Dr. Park?
Okay.
Further
got it.
aerial, right. We want to see the occipital part of the diagonal branches. Perfect.
Okay.
Perfect.
And you're ready? It's good.
Perfect.
Yes.
Yeah. All right.
We're gonna show us the OCT. And
OCT.
this is yeah. Just we use the pre-PCI one time and then final checking up one time. Yes.
Yeah. So I think that this session's two cases really illustrates and represents the title of our workshop, Complex PCI Make It Simple. so that all looks very complex and complicated
Yes,
techniques,
yeah.
but to our visual observation, whole procedure looks very simple.
Yeah. Today my condition is good. Okay. 준비됐어? 찍을 준비됐지? 자, 오케이. 자, 풀샷. Okay, got it. Just hand injection. Yes.
Yeah,
And then diagonal branch. 이거지?
Digital.
Yes. You can see there is a malposition or yeah, distal. Okay. Distal opposition is very nice and
Good.
well dilated. And also you can check it up the carina over here, slightly pull back. Over here, carina is not yet coming. Over here, okay, here, wide open. Can you show over there?
Yep.
It's a carina part. Okay.
Could you see
here.
that, right?
Yeah. And also proximal part opposition. Absolutely, there is a well opposed, no major dissection, is very perfect. So this is my final step showing the side branch.
Good.
Over here, okay.
Perfect.
오케이. 자, 준비됐지? 자, 오케이. 레디? 천천히. 오케이. Good. So, and we're gonna show diagonal branch.
Distal.
Distal part is well opposed.
Almost perfect. Right?
Yes, it's a well dilated 2.75 balloon. And then you can make sure it's carina part. Over here is well opposed. Is great. So this is carina, well open. And I think the result is excellent. So I'm gonna show final two shot. Okay, and you're ready. 자, first shot, good. And the area of cranial view. Okay, good.
I think it's perfect.
Perfect.
Yeah. So this is our representative case, OCT guided PCI. Today result is excellent. I'm very happy to introduce different taste. So
right.
you really enjoyed it's a OCT guided bifurcation PCI and step by step.
Good.
Okay,
Nice presentation, Duk-Woo Park. And you look a little bit tired, right?
Yeah.
Who's is getting sitting down or something? Okay. See you.
Thank you.
Preparing next cases. No,
Okay, thank you.
Okay.
Thank you.
You want to move to the Nanjing Foster Hospitals, Nanjing Medical University. Dr. Fei Ye. Can you hear me?
Yes, we can hear you
Alright,
clearly.
Great to see you. Thank you for joining us. I'm SJ. Dr. Koo as a moderator here. There's many distinguished panels here. All right, you want to start?
Okay, thank you. Thank you very much, Dr. Park, Dr. Koo. And I'm very happy to be here to have the live transmission from Nanjing First Hospital to the Korea. And on behalf of my boss, Dr. Shaoliang Chen, we will send a case with very interesting distal left main bifurcation lesion. But today, I will introduce my colleagues who will assist me to perform this PCI procedure. Dr. Yu Wei is my colleague, and Dr. Zhu Yong is also another colleague to assist me. And the IVUS technician was Dr. Pantao, will interpret the IVUS data, and we have a nurse working here for us. And we also prepare some special devices how to treat the severe calcification. So first of all, I want to ask Dr. Yu Wei to introduce clinical characteristics of this patient. Dr. Yu, please.
Okay, thank you, Chief. Dear moderators, panelists, and audience, good morning. Here is Nanjing in our case level 2. Today, our lab case is the 65-year-old gentleman who was admitted to our hospital for the recurrent chest discharge for 1 year, aggravated for half a month. And he's a current smoker, and he has the previous old myocardial infarction with the inferior wall. The laboratory test showed the patient has the acceptable renal function and the cardiac function. The ECG showed the Q wave in lead 2, 3 AVF, and we can also see the ST segment depression in lead V1 to V5. Patient has the good LVEF with the 65%, although we can see the hyperkinesis of the inferior wall motion. After the optimized drug treatment 1 month ago, we performed the coronary angiography for this patient, as you can show. Please show next slide. 下一张很好。Okay,
You can see the trap vessel disease also with the involved distal leveling bifurcation. And it's the right dominant. And because the patient family strongly refused the CBG, even if we have asked the consultation from the surgeons, they just refused. Without the other options, we performed the step PCI for this case. The right coronary is the carotid vessel, but with the very diffuse lung lesion from the proximal segment to the distal segment. As you can see, we performed the 3DES to cut the whole lesion. The result is very good. From the left corneal angiography 1 month ago, you can see it's the distal leveling bifurcation lesion. Next slide, 下一张 please. Okay, you can see the very true bifurcation lesion of the distal leveling bifurcation with the Manina 111. And also you can see the phenotype of the moderate to severe calcium just from the whole left main trunk extended to the proximal LAD. And also you can see the second diagonal got the total occlusion. Next, please. From the our chief Professor Xiaoliang Chen's definition study, the patients, although the patient qualified the 3 minor criteria, but unfortunately does not qualify for the major criteria. So we judged the case just a simple bifurcation because the from the angiography, the coordinate you can see very clearly the ostium of the circ is not so severe, and the length is less than 10 millimeters. So it's a simple bifurcation. Next slide, please. We also checked the QFR for the 2 vessels LAD, which is the 0.37, very tight. Next, please. For the circ is the 0.65, also significant lesions. Next, please. Routinely in our CAS lab, we perform for the chip PCIs. We follow our mentors, Professor Ye. We always to calculate the risk scores for this kind of the PCI. The syntax score 1 is 40, more than 32 is high risk level. The syntax score 2 shows the patient has the 4-year mortality for PCI just comparable with the KBG. And the nurse score 2 also first mentioned by Chief Professor Xiaoliang Chen, and just to judge the unprotected left wing bifurcation lesions. For this case, the nurse score 2 is 24.22, also more than 9 score. So it's also the high risk levels. Next, please. So strategy for this case. And we all know that in this year's the ESC guidelines just for the complex PCIs, the intravascular guided PCI has the 1A level recommendations. So IVUS or OCT for this case, which is the best, and we need your recommendations. It's the simple distal bifurcations. Seems like the provisional standing is suitable. Do we need the two-stand technique because the QF for the circ is also significant? And for the mechanical circulatory support device, do we need to use for the patients? After all, it's the chip case. If we use IBP or ECMO, because we don't have the impeller or the tandem heart in our Chinese market. So that's all for this case. Thank you.
Yes, go back to today's angel.
Okay, Chief.
Yes. So for the main screen, we can see the RCA was very good after standing several weeks ago. And today's angel for the left coronary artery. Just because when we use 7-French 35 EBU guiding catheter to engage the left coronary artery, we found the pressure was not very good. So we use a wire protector tactic to avoid the dumping pressure during the left coronary guiding catheter engage. So after we use a workhorse wire going to the distal LAD. So next. So what's the strategy now? I want to get some recommendation from the panelist and the chairman.
So it seems that you already implanted the IABP there. So
yes.
Is it kind of prophylactic, or did there something happen to the patient during the preparation procedure?
No, the patient feels good during the procedure. For the previous planning for the case, we found the severe calcification during the first angel. We prepared to perform some treatment strategy just by the ROTA or shockwave balloon to treat the left main. So after that, we want to put the IPP previously. So what's your strategy if you want to treat this left main or the whole left main disease with severe calcification?
So I think that in this case, intravascular imaging should be the first to determine the risk of procedures and also whether this kind of hemodynamic supporting is needed or not. So that and also for the provisional or to stenting, intravascular imaging may be the key.
Okay. So before we use the IVUS detection for the distal left main and proximal LED, we opening the second side branch. After that, we found the second side branch was very good, very large enough. So after that, we use 1.5 balloon, pre-diet. After that, we check the LED IVUS. So could you show the IVUS data to the main screen? Yes, this is Dr. Panda. Would you interpret the IVUS data?
Okay, let me show the IVUS imaging. Can you see the IVUS imaging?
Yes, we can see it.
Okay, I will pull back. The first round, we check IVUS from the distal LAD to left main. And here, this location, the IVUS catheter is in muscle bridge. And then pull back near the muscle bridge, we can see eccentric plaque. The plaque is the attenuation plaque and the calcified plaque. And the vessel diameter is about 3.0 millimeter. Then go and pull back. Here, this location is the LAD and the diagonal bifurcation. Over the bifurcation, and here, this location, we can see the calcification angle is more than 300 degrees. Then pull back. This is the proximal LAD. The proximal LAD vessel diameter is about 3.5 millimeter. And here, this point is the minimal lumen area. And the area is just 2.5 millimeter square. And the plaque burden is more than 76. Then go and pull back. This is the proximal LAD. And here, this location, near the ostium LAD. And here, this bifurcation is the circumflex. And this location, the area is just 2.6 millimeter square. And the plaque burden is about 69%. Then go and pull back. This is a POC, and this is a distal left main. The distal left main area just 3.4 millimeter square. Plaque burden is more than 70%. And here, the calcification angle is about 300 degrees. Then go and pull back. This is the middle left main. The middle left main vessel diameter is about 3.8 millimeter. Then go and pull back. This is the ostium left main. When we draw from the distal landing rule to ostium left main, the netness is about 57 millimeter. And from the distal landing rule to LAD and the diagonal bifurcation, the netness is 23 millimeter. The second round, we check IVUS from the circumflex to left main. The circumflex, the area is very small, so the IVUS catheter can not to do very distal. And from here, the location, the area is just 2.0 millimeter square, and the plaque burden is about 74%. Then pull back. Here, this is the proximal circumflex. The circumflex vessel diameter is about 3.0 millimeter. Then go and pull back. This is the PR. Then go on near the ostium circumflex. This location is the ostium circumflex. The area is about 3.9 millimeter, but the plaque burden is just 4.9. And the netness from the IVUS begin to ostium circumflex is more than 22 millimeter. Okay, this is the baseline IVUS imaging. Thank you.
Thanks for Dr. Panda's interpreting of the IVUS finding. So any suggestion from the panel and chairman how to treat this bifurcation lesion with 2 or 1 stent tactic? How to treat the calcification lesion located at the proximal area and left main?
I think the main issue is how to deal with this calcification. So
Yes.
unfortunately in Korea, we are not, the IVL is not available, but as you have it, because that the distal, more than 300 degree calcification, the lumen area is around 2, so that the conventional rotation atherectomy may not work very well, but the IVL may work so that and another very important element is that the left main bifurcation, Cirque also was quite good, but the opposite side, there was a very huge eccentric calcification. Unless you break it, you'll have a significant jailing of that ostium. So if feasible, IVL may be the primary option for this case.
Thank you.
Dr. Ye, would you show us the RAO view, RAO AP error? I want to just say that circumflex part artery. You do
RAO. No, IRO. IRO cranial.
Circumflex.
I will show it to you.
All right.
Next. Yes.
Circumflex ostial part.
You mean RA quarter or LA quarter? Yeah.
This got
Yes,
All right,
that's
right. I think it's better. It's better. All right. So many options, right? Diffuse disease even in the circumflex artery, right? So we have to.
That's right.
Very, gotta worry about long stent for the bifurcation lesion. However, you're gonna pick up the long stent for the LAD, no doubt about that. And so anesthesia, I don't care about the first diagonal branches, obstructed ones, CTO one. If I think it's just reveal alone is quite good. However, you have already, open up the diagonal branches, and so depending on the size, you can do something. So, issue is circumflex, proximal, right? How do that one? So, I want to treat anyway partial, proximal part, just. A stent or stent, 2 stent with a short circumflex stent. That is my just consideration.
So Dr. Ye, what's your strategy for today?
Mm-hmm.
Yes, and yes, based on the IVUS finding, we found. Yes, sorry.
Mm-hmm. So
yes, based on the IVUS findings, the minimal luminal diameter of the severe calcification was over 2. So we don't think ROTA is useful for this calcification. So we want to use IVL to treat the proximal LAD and left main severe calcification. So we want to use, based on the IVUS finding, the reference diameter of the proximal LAD was 3.0 and left main about 3.8. So we want to use a 2-size IVL. One is a 3.0 to treat the proximal LAD severe calcification, and with a 3.5 to treat the left main severe calcification lesion. So this is 3.0.
So
the domestic.
Yeah. Okay. So that I heard that the domestic one is working very well, and you already published the paper.
Yes. Yeah.
So this is 3.0, right?
3.0, 12, domestic.
Okay.
No. Okay, 3.0. So with 4 atmosphere and go up to 6 atmosphere, this is domestic IVL from Liverpool company in China. So we should push a little bit.
So there's small indentation at, okay, good. So it's great that the even 3.0 IVL balloon passes very well along that heavily calcified lesion.
Yes.
So how many times did you shock for this calcification?
We have 8 rounds
8
totally.
rounds? Okay.
Yes, 8 rounds totally. But if we inflation the balloon, we find some small bubble in the balloon. So we will check the flush again, and yes, Lucy.
Very tight.
No. Give me contrast.
So you want to remove the bubble inside the balloon and rerun the IBL.
Yes, that's very important if we use IBL.
Yeah, it's acoustic energy. So if there's a kind of inhomogeneous materials there, the effectiveness will be less and less.
Yes, it's very important. If we found some air bubble in the balloon during the inflation of the IBL, so it should decrease the effective of the IBL. Okay. Maybe we inflation the IBL. For the first or second times, we found the inflation there is low air bubble. But after 3 or 4 times, we will find some air bubble occurred during the inflation. So we will. Okay, again. Oh, no, stop. Just still air bubble. Look at here. So we should. Give me. Okay. Inflation. Yes. Lose it. Yes. So. Okay. 조금.
This generally does not cause this kind of big air bubble problem in the other sessions, but it's very strange that this case has big bubbles inside. Okay. Now it's good.
Yes.
But it seems that it's already fully open, almost fully open.
Yes.
There must be some.
After several rounds, we check with IBL. So if we found the calcification cracked, so we can use 1-to-1 NC balloon to pre-dilate again. After that, we check. We found the.
Okay, good.
Okay, good. No.
Okay, so there was no balloon there, but after, so bubble is now the increasing. So here you see after the shock, bubble number and size increases.
Yeah.
But it is acting, right? So lumen has been definitely increased a lot. So cracking must have happened.
Yes.
And you are going to use a larger balloon, 3.5?
That's right.
Okay.
We will use a 3.5 IVR to treat the left main. So, Dr. Penta, could you tell us the left main's?
Yeah.
Left main's lesion location, the distance between here to the circumflex. Give me 3.5 IVR.
Yeah, we're preparing.
So if we use the IVR to treat the left main severe calcification with the IVR, our previous experience, we want to use IVP or ECMO to support the left ventricular function, just because we will use a balloon to pre-dilate to inflation in the left main for a long time.
Okay, so I understand. And I think that in this very eccentric lesion shape, it's very important to select the adequate balloon size, because that if balloon surface cannot touch the full area, the effectiveness will be very low in this case. So you have to select the size according to the longest length of the circulation images. And so I think that 3.5 may be proper for this left
Yes.
main IVL procedures.
Yes, yes.
So Dr.
You need the
Ye,
balloon? Yes.
yeah, IVL is not available in Korea. So how long do you have to inflate the balloon during the IVL procedure?
Yes. Thank you for your question. If we routinely we inflation the IVL during the it works. Every round we use 10 times. Every time lasts for 1 second. So inflation totally over 10 seconds. After that, we use full atmosphere inflation during it works. After that, we stop IVL and we increase inflation atmosphere to 6 atmosphere, maybe after 5 to 10 seconds, and that totally we deflation the IVL balloon. If we found the IVL balloon totally inflation, we will change to another direction or another position for the IVL work.
Okay.
So
also,
I think for yes.
Yeah, I might have missed the slide. What was the ejection fraction for this patient?
I'm sorry?
Left ventricular ejection fraction for this patient.
Yes, left ventricular fraction. EF value was how about the EF value?
65.
Yes.
Yeah, but for 65%.
65%. Yes. Flashing. Yeah. 等一下，看有没有气泡。Still elbow. Okay, down. Okay.
Yeah.
So we use another 3.5 IVL made by local domestic Chinese company to insert to the left main. So we try. Okay. Yes, here. Okay.
4.
Okay. Inflation.
Okay, now it's expanded. Yeah, calcium.
Yes.
Yeah, eccentric calcium has been broken. Cracking happens.
Go down. You can hear the sound. If the second sound shows last longer, so that means we should deflation. Yes. Yes, no problem. You can see if we put IBP before IVL to treat the left main, we can see the blood pressure, heart rate is very, very stable.
Yeah, despite the very significant changes in ECG, the blood pressure itself is very stable. So.
Yes. Down. Up. We can see a phenomenon. There is rupture of the IVL.
Yeah.
Maybe we met some problem of the. We can check. Show me the blood pressure is okay, heart rate is okay. We can check the IVUS. Could you go back to the IVUS finding of the left main, Dr. Pantau? There is Kefei Dou or something. We check the IVUS. IVUS, show me. IVUS.
Okay.
Yes. So test for angio. We found there are some dissection. Okay, flow is okay. We check the IVUS. So, for my personal opinion, if we find the classification or original classification during the IVUS finding or OCT finding, direct IVL is not very useful for this kind of situation. If we met some concentric classification with smooth surface of the classification, okay, IVL is better. So compared with eccentric, concentric classification is okay.
Yeah, I will put back. Distal near the muscle bridge.
Yeah.
The distal LAD.
Give me 3.5 NC balloon.
This is the medial dissection. This is a diagonal. And here we can see one crack.
Yeah, crack and
Yeah,
further dilatation.
this is a proximal LED.
There's also
Medial
dissection
dissection.
there.
Yeah. It's near the ostium LED. This is the circumflex, the distal left main dissection. Okay, this is the ostium left main.
Yeah, there's several,
Okay.
cracking of the calcium is there. So Dr. Fei, you have only
Yes.
1 minute.
Okay.
So can you just explain your further procedure? Because it's great to see that the most of encircling calcification, there's a crack there, so that so there will be no significant problem of the doing further procedure. So can you briefly explain the coming procedure before we leave you?
Thank you very much for Dr. Park, Dr. Koo, for inviting me to have this transmission. And I think previously we want to show the two-stand technique to treat this left main bifurcation aging from the angio finding. But after we check with IVUS, we find the ostial circumflex was not very severe, significant. So we want to treat the left main and LAD severe calcification with IVR just because I was finding the minimal luminal area at the target lesion was over 2. So IVR is very useful for the concentric calcification, but compared with eccentric or calcification, I think it should be combined with other treatment devices just like JOTA or OPITS, but OPITS is not available in China. So for this case, we want to use IVI, just IVUS guided PCI to treat with some special devices to treat the severe calcification. And after that, we want to pre-line it with NC balloon. Then we treat the LAD to the left main with two-stand technique for this case. After that, we want to protect the diagonal and the circumflex with wire. If there's some compromise of the side branch or osteo, we want to do wire and the casing. After that, we use a drug-coated balloon to treat the side branch. This is our next plan for this case. And thank you, even though there is no time, thank you very much for Dr. Park, Dr. Koo, for inviting us, Nanjing First Hospital, to have this live case transmitted to the Korea. Thank you.
Thank you, Dr. Ye, and for team for the great illustration how the IVI and IVL can make simple of this complicated left main lesion. So I think now it's time to move on to the featured lecture. So the speaker will be Professor Kefei Dou from Fei Ye Hospital, China. And today he's going to talk about side branch occlusion risk prediction score during left main PCI. Professor Dou, please.
Okay, good morning, and friends and colleagues. I'm Dr. Dou from Beijing Fei Ye Hospital. It's a pleasure to be here to talk about the score system predicting the side branch occlusion when we treating left main bifurcation. Nothing to disclose, and we all know left main bifurcation lesions is always the focus of PCI because it is associated with increased mortality. And I think most of the interventional cardiologists take provisional stenting as the standard approach. However, we also found the two-stent strategy is superior than provisional strategy in more complex left main bifurcation lesions. So I think the most important thing is to figure out which is the high-risk bifurcation before we start our procedure. And in the past decade, we have published some paper regarding result score series for the prediction of side branch occlusion. Some decided based on QCA, some based on visual estimation. It has been recommended by some expert consensus and even guideline in China. We also have done some work. V-resolve score has been validated in left main bifurcation, whereas several including factors did not have predictive value. There are two reasons. One, development cohort of result score only including the less than 5% left main bifurcation lesions. Another is anatomical differences exist between left main and the non-left main bifurcations. So it's time to develop a left main bifurcation specific scoring system to predicting the risk of side branch occlusion. And I used a consecutive left main PCI cohort, 1,300 patients. After excluded around 300 patients and they went elective two-stent strategy. Finally, I had 855 patients and used it as a development data set. And we collected the left main bifurcation anatomy information by visual estimation, including baseline diameter stenosis, reference vessel diameter, lesion length, plaque distribution, TIMI flow grade, bifurcation angle, and other lesion characteristics such as calcification and tortuosity. We also checked the QC in order to test whether the visual estimation is correct or not. Our study primary endpoint is the side branch occlusion, defined as any decrease in TIMI flow grades or absence of flow in the side branch immediately after full apposition of the main vessel stent to the vessel wall. Secondary endpoints include peri-procedural myocardial infarction and the single stent failure defined as a composite of final side branch occlusion and bailout stenting in the side branch. And we found baseline characteristics and it's well balanced between the no side branch occlusion group and the side branch occlusion group. We also found a higher risk of side branch side plaque, higher stenosis of main vessel at the side branch, longer side branch lesions in the side branch occlusion group. And we also found a higher risk of side branch stenting and PMI in the side branch occlusion group. And we used the logistic regression to figure out what is the risk factor of the side branch occlusion during left main PCI. And finally, attributed integral number to the variables to generate a risk score. And we, in this risk score, included 3 parameters. It's very simple. First is main vessel plaque distribution. And one, the plaque distribution is at the side branch side, it's 6 points. The second one is the main vessel side branch diameter ratio. When this ratio is greater than 1.5, it's 2 points. And last one, the most important one, side branch baseline stenosis. And when the stenosis rate is 70 to 90%, it's 3 points. Greater than 90%, it's 7 points. And the prediction model and the risk model showed excellent discrimination and satisfactory calibration, and the C-statistic value all around 0.83. We also use the 5-foot cross validation and the external validation, and to also validate that the risk score is very useful to predict the risk of side branch occlusion in left main PCI. And after check QC and the visual estimation and the QC data show the moderate agreement. And finally, according to left main visual score quintiles, left main bifurcation lesions were considered as low risk, quintile 1 to 4, less than 8 points. And the high risk group and quintile 5 score greater than 8 points. We can see here, if it's a high-risk group, the side branch occlusion rate is 77.4% versus 0.6%. And the single stent failure rate, high-risk group is 16.7% versus 3.7%. And that means when we start our procedure, if you calculate score, see if it's in high risk group, we need to treat it aggressively. And actually, in my cath lab for left main lesion, iris usage is 100%. But iris also has some drawbacks. For example, if there is a very severe disease, the lesion exists, it's difficult to perform exam. And also, the patient sometimes can't tolerate iris exam. Other reason, because iris cost sometime longer procedural time and extra cost, and learning curve for the doctors a little bit longer. So I think the left-main visual source score can be used as a complementary to iris. Even now, the PCI is in an area of intravascular imaging. And the present study was published on Canada Journal of Cardiology this year, and we also got patent application approved by CNIPA. Finally, I want to make a brief summary. Left-main visual score could rapidly and accurately predict side branch occlusion in left-main bifurcation with good discrimination and calibration. The risk score includes 3 factors: main vessel plaque distribution, diameter stenosis of side branch, and main vessel side branch diameter ratio. High-risk lesions identified by left-main visual score had an increased risk of side branch occlusion, single-stent failure, and peri-procedural myocardial infarction. And thank you for your attention.
Thank you for a nice presentation. We're going to move to the next featured lecture of this session. The title of lecture, Conceptual Education of Bifurcation PCI. The lecture presenter is Bon-Kwon Koo from Seoul National University. Please, Dr. Koo.
Thank you, Professor Hong, for the kind introduction. So this is my disclosure. So since the first kissing balloon angioplasty by Dr. Grunchi in 1981, there has been an enormous evolution of bifurcation PCI in terms of device, technique, and researches. However, I'm afraid that to say that we are in the kind of plateau stage, so to overcome the upcoming issues related to bifurcation PCI and to make another peak, I think it's good to review the conceptual evolution of bifurcation PCI. So the most common and easiest concept of the bifurcation PCI is fixing the stenosis for the patients. However, this concept is not that helpful to solve all these complicated issues we have to deal every day. And so we need to go into the deeper concept, I think, which is that the fractal structure and ratio. So there are several laws which are a little bit complicated to illustrate this ratio, fractal structure, but the simple understanding of this fractal ratio is D1, D2, D3 are not the same. And if you go back to the history, it's surprising that this concept has been established almost 100 years ago. And following establishing that concept, there has been several pivotal trials that this fractal structure is actually the basis of plaque development in bifurcation area, plaque progression, and vulnerable transformation. So basically, I would say no fractal structure, no bifurcation PCI. And several decades later, we know that this concept has been applied to technical issues such as a Carina shift, POT, and imaging criteria. All are based on this fractal ratio. So again, no fractal ratio, no bifurcation PCI. And it's not surprising that this fractal ratio concept has been evolved into the discordance between anatomy versus physiology, because one of the main mechanisms of this discordance between angiography and FFR in side branch is the fractal structure and associated Carina shift. However, it's very surprising to see that even in the very early beginning of the intracoronary angioplasty, the pioneers did the intracoronary hemodynamics. As you can see in this figure, published in 1984, our pioneers already measured intracoronary pressure in main branch and side branch before, during, and after balloon angioplasty, even though they had to use 2 guiding catheters and over-the-wire balloon. And now it's become a kind of common sense. So there are discordances between anatomy and physiology, but this concept is not enough to understand why there are no differences in clinical outcomes between FFR-guided versus angio-guided PCI in bifurcation lesion, unlike the FAME trials. There was no difference in registry and even no difference in clinical outcomes in this randomized trial. And then we got to understand that there should be something more important than physiology or ischemia in bifurcation lesion, and that's the concept of clinical relevance. So we have to deal with two different things in bifurcation PCI. One is physiological indices or ischemia, and the other is percent myocardial mass risk. As you can see here, the area can be varied between 2% to 20%, and you got to understand if you're dealing with only the numbers, FFR 0.552 is much worse, but if we integrate these territory or clinical relevance and physiology, you can get to know that 0.73 is much worse index than 0.52 in the bifurcation lesion, and that's the base how and why there are several papers that pursue the assess of myocardial clinical relevance of side branches using this scoring system and CT fracture myocardial mass or the machine learning based decision tree for significant branches. And all these efforts have now been integrated in these consensus paper published in 2022, Korean, Japanese, European bifurcation club consensus and bifurcation ARC documents both stress the importance of clinical relevance above the physiologic assessment, and now we have a concept that the clinical relevance of side branch is the first step in side branch assessment rather than angio, OCT, IVUS physiologic assessment. And it's also surprising to see that this is actually the first paper published on bifurcation PCI, published in January of 1984, and the last sentence of this paper finished with the words of relevance of side branches at risk. But the question is, the relevance we are dealing with the myocardial mass risk has the same meaning of the relevance of side branches in that paper published in 1984, but unfortunately, it's not. Because here are two big diagonal branches and big ramus branches, unfortunately totally occluded after membrane stent implantation and failed to revive. So that according to this myocardial mass risk, territory seems to be similar. So we have to expect the similar consequences, but the consequences are totally different. Left one, no symptom, no regional wall motion abnormality, and right one, papillary muscle rupture, cardiogenic shock, and cardiac death. So that the myocardial mass risk, simply 10%, 15% may not be enough. So for that, we have to understand that our concept should evolve into the structure-function relationship. So here is the way we do assess the clinical relevance using the percent myocardial mass risk, 25%, 10%, 14%, 28%. It's nice. But to understand these dramatic differences in clinical outcomes after occlusion of that branch, we have to go into the deeper. For example, assessing the papillary muscle blood flow is key importance in understanding these differences in clinical outcome. So our concept have to be evolved into the macrostructure and function relationship as well. So I don't want to go into the very detail of this very complicated figures, but we have to understand that the lesion features such as luminal narrowing, plaque burden, plaque quality or vulnerability, and hemodynamics versus clinical event risk is different between main and side branches. As you can see that the sheet of the blue sheet and red sheet are separated. You see the differences in these relationships. And another very interesting question is why there's no regional wall motion abnormality even in resting MR and also during exercise, despite the very relevant ischemia in that area. For that, we have to understand another more complicated microstructure function relationship to understand the regional differences in infarct development and protection or ischemia resistance. And that's the reason why we have to go into the deeper from the epicardia to the microvascular structure to understand this microstructure and function relationship to provide the adequate treatment and to understand the clinical events happening after the procedure. So we know this technical evolution of bifurcation PCI very well. And in previous 8 minutes, I've discussed about the conceptual evolution of bifurcation PCI. And now I'm wondering, where is your conceptual evolution staying? Thank you very much for your attention. Okay, so I think we have some minutes to go. So any questions and comments about two topics from the panel will be appreciated. So we have 1 minute to go.
I have one question to Professor Koo. Do you recommend from your lecture for small blanch, side blanch, even side blanch gel, but patient don't and no any chest pain, no itching, you recommend don't touch. But I think for a young interventionist, more happy to open the side blanch, like immediate good roll. So what do you recommendation? Please don't touch or maybe?
I think that's an important clinical question. So I don't think that you don't need to treat this lesion. Maintaining TIMI flow is important for most bifurcation, most branches, but whether put another stent or not is a very important issue. So we learned this today's 2 live demonstration. First, Dr. An's case, maintaining TIMI3 flow was enough, but another Professor Bak's case, we learned that the 2 stenting, upfront 2 stenting is necessary. So it's not meaning of the treat or not, but maintaining TIMI3 versus putting another stent concept, we have to use that kind of issues to that.
Thank you.
So I have some comment on just the IVL in left main patient. So I think for IVL 10 cycle, 10-second occlusion is usual. But for some patients may not tolerate that 10-second balloon inflation in the left main, especially for those with RCA, CTO, or dominant left main disease. Sometimes I may shorten it to 3 or 5 cycles and then defay immediately. Even though with impeller support, I have encountered cases of cardiac arrest while an impeller if you are obsessed about the 10 cycle. So the other thing is the balloon preparation, use of freeway and prep it like a stingray balloon. So you have to prep it very meticulously to avoid the bubble, because bubble would decrease the effectiveness of your IVL. This is all, my comment.
Okay, so for the sake of time, we have to close session. And on behalf of the co-moderator of this session, Professor Bak, I'd like to thank you all the speakers and great live demonstrators, and also from the live demonstrator from the China and speakers also the audience for the active participation and the panels. Thank you very much, and I close this session.